Overdiagnosis is the detection and diagnosis of a condition that would not cause symptoms in the patient's lifetime or death from the condition. It results in labeling with a lifelong diagnosis, as well as unneeded treatments and surveillance. A patient who is overdiagnosed cannot benefit from the diagnosis or treatment, but can only be harmed. Studies of cancer overdiagnosis have used various methods and have found an extremely wide range of results. We ask the question, what methods have been used for measuring overdiagnosis from cancer screening, and what are the strengths and weaknesses of each method? We searched PubMed and Embase for studies of any design that quantified overdiagnosis of cancer resulting from screening in an asymptomatic population. We evaluated studies and the body of evidence for risk of bias, directness, analysis, time frame, external validity, precision, and consistency. We summarized the strengths and weaknesses of the various methods of estimating overdiagnosis as follows. Follow-up of randomized controlled trials minimizes risk of bias and answers the question of interest directly. Weaknesses are related to the long duration of these studies and to the ways in which subjects differ from the general population. Modeling studies estimate the way cancer would hypothetically progress without screening, and then the way cancer progresses with screening, comparing the two to determine the frequency of overdiagnosis. These studies have certain strengths, but also many weaknesses, related largely to dependence on assumptions. Pathologic and imaging studies, by assessing tumor characteristics, estimate overdiagnosis resulting from non-progressive disease. They provide a simple approach, well suited for monitoring overdiagnosis over time. Since they cannot account for competing mortality, they underestimate total overdiagnosis. Their validity depends on acceptance of assumptions and on rigorous data collection. Ecological and cohort studies, when well designed and interpreted in combination with studies from other geographic areas and temporal periods, can provide credible estimates of overdiagnosis. They are also suitable for monitoring of real-world overdiagnosis over time. These studies, however, can be limited by confounding, time and case ascertainment demands, and problematic analyses. Our systematic review highlights the high potential for bias and the reliance on unproven assumptions in modeling studies and studies that quantify overdiagnosis using pathologic or imaging characteristics. Although ecological and cohort studies have several weaknesses, some studies dealt convincingly with these and provided evidence with reasonable certainty. Our review suggests that well-conducted ecological and cohort studies in multiple settings provide the most appropriate approach for quantifying and monitoring overdiagnosis in cancer screening programs. To support this work, we need internationally agreed-upon standards for ecological and cohort studies, and a multinational team of unbiased researchers to perform ongoing analysis.